My hello and good evening to all of you. I hope I'm audible. Can you all hear me? Those who are connected with me in the live YouTube chat, can you confirm whether I'm audible? So this is a live lecture, Back2Clinics Series. I am Dr. Sachin Arora, Psychiatric faculty at AIIMS. I am a consultant practicing psychiatrist for last 8 years in Dwarka, New Delhi. So today I am here to talk about a very famous topic in psychiatry called insomnia. So we are here to discuss approach to a patient with insomnia. Insomnia is the commonest psychiatric complaint that we encounter in day-to-day practice. Okay, the first thing that the patient comes with complaint, the most common thing in a psychiatry OPD is actually insomnia. Sir, I can't sleep. I can't sleep. I'm unable to sleep. I can't sleep. I'm unable to sleep. So those connected with me in live chat, hello. Am I audible, visible to all of you? Okay, so I'll be bilingual in this topic. The agenda of the talk today is identifying what is insomnia, approach to a patient with insomnia, how the patient presents, what can be the different causes of insomnia, what are the different management options. आज मैं 5 चीज़ें बताने वाला हूँ आपको. मैं बाइलिंगुअल रहूँगा ताकि इंग्लिश हिंदी दोनों तरह के स्टूडेंट्स को ये लाभदायक हो, ये हेल्पफुल हो. First in English, approach to a patient of insomnia, how the patient presents, what are the chief complaints, how do we diagnose insomnia, what are the causes of insomnia, then what are the management options, pharmacological and non-pharmacological. I'm sure this a short presentation of 20 to 30 minutes is going to definitely help you. I'll keep it as simple, as candid as possible, not going into the complicated details, but a basic management approach. I believe all MBBS doctors are supposed to know how to handle a patient with insomnia. So let's begin. Let's begin with the definition of insomnia. साइकेट्री ओपीडी में जब भी हम बैठेंगे सबसे पहला पेशेंट जो आएगा वो है इंसोम्निया. और इंसोम्निया का मतलब ये नहीं है कि नींद नहीं आ रही. इंसोम्निया का पेशेंट का मतलब है I am not satisfied with my sleep. I am not satisfied with my sleep. Unsatisfied with sleep. It can be poor quality. It can be poor quantity. Poor quantity means inadequate sleep. Now this inadequate sleep is a very subjective definition because the individual sleep requirement matters. Individual sleep requirement differs. Some person who is supposed to sleep 8 hours every day and is getting 6 hours sleep, that is also insomnia. And some person who is sleeping 6 hours always and today also sleeping 6 hours is not an insomnia. So do you get the first point? That is, the definition of insomnia is unsatisfied with the sleep. That is, could be less quality or that could be less quantity. Both are insomnia. Less quantity or less quality. There are 4 things: difficulty in initiation of sleep, difficulty in maintenance of the sleep. Initiation means after going to the bed, having more time in getting sleep. That is what we call as sleep latency time. Sleep latency time is defined as time taken from when you go to bed, close your eyes, wish to sleep, and from there when you get sleep. Some people get sleep within 5 to 10 minutes, some people get within 15 to 30 minutes. Normal sleep latency is up to 15 to 40 minutes. So if you are taking more than 40 minutes to get into sleep, this is also increased sleep latency type of insomnia. Then difficulty in maintaining sleep. What do you mean by difficulty in maintaining? Frequent nocturnal awakenings. So how do you take history of a patient from insomnia? Patient comes to you, sir, I can't sleep. First find out whether it is quality problem or quantity problem or both problem. It can be only quality, it can be only quantity, or it can be both. And if it is quality problem, is it more getting affected from the beginning or more getting affected from the morning? Example, previously the person used to sleep 10 p.m. to 5 a.m. Now he is sleeping at 12 to 5. So it is 5 hours, but it is getting cut from the beginning. This is difficulty in initiation. He goes to the bed at 9:30. Previously he used to get at 10 p.m. Now he's getting 12 midnight. So it is difficulty in initiation. Second example is 10 p.m. to 3 a.m. This is what is called as early morning awakening. So do you understand? So when you get a patient of insomnia, you have to find out this problem or this problem or this problem. Difficulty in maintaining sleep, the frequent nocturnal awakenings, that is poor quality of the sleep. And sometimes the patient says that I am not satisfied with my sleep. This is how you understand insomnia. मैं फिर से बोलना चाहूँगा, अगर आपके पास नींद ना आने वाले का पेशेंट आता है, आप उनसे क्लियरली 4 सवाल पूछेंगे. नींद आने में तकलीफ हो रही है, आने के बाद मेंटेन करने में तकलीफ हो रही है, या सुबह जल्दी नींद खुल जा रही है, या फिर आप अपनी स्लीप से सेटिस्फाइड नहीं है. आर द 4 पॉइंट्स क्लियर? अप्रोच टू अ पेशेंट विद इंसोम्निया. इंसोम्निया का पेशेंट ओपीडी में आया, इंसोम्निया पेशेंट कम्स इन ओपीडी. You have to elaborate this chief complaint. In history taking, we are always taught HOPI, history of present illness. So how do you elaborate insomnia? Is that clear? All of you understood the definition? All of you understood the 4 questions to be asked to a patient of insomnia? This will decide our diagnosis. This will help us in management. Do you get my point? I am keeping it very basic, very simple, very lucid for understanding of anyone. MBBS doctor, the private practitioners, anyone can benefit. Okay. Insomnia is not defined by the number of hours one sleeps every night. It is the quality of the sleep and the daytime consequences which determines the diagnosis. Do you know why the people of insomnia come to us? Sir, if I don't sleep properly in the night, I am unable to perform properly in the day. Why insomnia is a problem? Because we are not able to function properly in the daytime when we have not slept properly the previous night. Do you agree? Do you agree that when we are not able to sleep properly on the previous night, we are not able to function properly the next morning? So the daytime consequences matter. Daytime consequences matter. That's why people come with a complaint of insomnia. Okay, now insomnia can be of 2 different varieties. One is called a primary insomnia without a psychiatric diagnosis. One is called a secondary insomnia with a psychiatric diagnosis. So the 2 types of insomnia are primary and secondary. The 2 types of insomnia are primary and secondary. Have a look at this. Most of the time, insomnia is due to a comorbid psychiatric diagnosis. The most common insomnia is not a primary insomnia, it is secondary insomnia. Mostly it is an underlying diagnosis. Primary insomnia account for approximately 16% cases. Primary insomnia means without a psychiatric diagnosis. Secondary insomnia means with a psychiatric diagnosis, and the management differs. If there is a secondary insomnia, we focus more on treating the underlying cause. Whatever is the underlying cause, we focus more on treating the underlying cause. For example, one of the common causes of insomnia is anxiety. So if it is a anxiety causing insomnia, I prefer to treat anxiety so that it takes care of the insomnia. But if it is a primary insomnia, we prefer a pure hypnotic kind of a drug, the drug that help to induce sleep. There's a difference between, for example, in anxiety management, I shall be using a sedative hypnotic versus in primary insomnia where I shall be using a pure hypnotic. This concept needs to be understood properly by all of us. The drug that makes a hyper person normal is a sedative, and the drug that makes a normal person sleep is called hypnotic. So technically, every sedative in low dose is a hypnotic in high dose. So suppose you are anxious and I give you, let's say, 0.25 milligram of clonazepam, you become normal. But suppose you're normal and I give you 0.25 milligram of clonazepam, you immediately go to sleep. That's why example of sedative hypnotic drug is a benzodiazepine. So if it is an anxiety causing insomnia, we prefer a benzodiazepine group of drug, versus if it is a primary insomnia, we prefer Z group of drugs like zolpidem. Do you understand the concept of using zolpidem here? Zolpidem is a pure hypnotic drug as compared to benzodiazepine, which is a sedative hypnotic drug. Do you understand this concept? अगर इंसोम्निया का कारण एंजाइटी है तो हम एंजाइटी को ठीक करेंगे तो इंसोम्निया भी ठीक हो जाएगा. अगर एंजाइटी वाली दवाई दोगे, एंजाइटी डाउन, तो नींद आएगी. लेकिन अगर एंजाइटी कारण नहीं है और प्राइमरी इंसोम्निया है तो मैं प्योर हिप्नोटिक ड्रग प्रेफर करूंगा. डू यू अंडरस्टैंड दिस बेसिक मैनेजमेंट ऑफ फार्माकोथेरेपी? तो सबसे पहले हमने फाइंड आउट किया वेदर इट वाज अ प्राइमरी इंसोम्निया और एंजाइटी कॉजिंग इंसोम्निया. It's not that just anxiety causes insomnia, there can be other causes also. What are the different illnesses that can cause insomnia? One of the commonest is anxiety disorder. Second commonest is mood disorder. Suppose it is depression causing insomnia. It is very common for depression patient to have insomnia. So I will prefer treating them with antidepressant rather than giving a pure hypnotic drug. Once the depression goes, insomnia will also settle. Actually, depression and insomnia, exaggerated depression is a cause of insomnia. So they have a dual relationship kind of a thing. So more insomnia means even the worst prognosis in depression. Do you understand this? Please, people who are attending live, if you can respond in the chat, it will appear to me that you are understanding what I am telling. This is not a proper, psychiatry teaching of NEETPG. This is how we manage a case of insomnia. Insomnia patient can come to any of you, any physician, any consultant, any MBBS doctor can get a patient of insomnia. All of you can get insomnia. Your brother calls you, I can't sleep. Your father calls you, I can't sleep. Your mother calls you, your relative call you, I have an exam tomorrow morning, I can't sleep. Please understand that an MBBS doctor is supposed to know the medicine for sleeping. Just imagine somebody calls you that I can't sleep, and you being an MBBS doctor are not able to prescribe the proper medicine. Doesn't that look, something incomplete? Because when I completed MBBS, I was not knowing how to write a medicine for insomnia if any of my relatives suffers from insomnia. Because every insomnia is not a psychiatric diagnosis. 14% of all insomnia, 16% rather, don't have a psychiatric diagnosis. Thank you so much for responding, Sham Kansal, Kapilveer Singh. Thank you so much for responding. Do you understand this? If no other symptoms of any psychiatric illness are present, we diagnose as primary insomnia. Insomnia is diagnosed by presence of this: difficulty in initiation, difficulty in maintenance, difficult waking up early in the morning, non-refreshing sleep. I am repeating the first slide for those who joined this chat later. So it is not the quality, it is not the daytime consequences of not sleeping. Do you agree that daytime you are not able to perform properly if you have not slept properly the previous night? Do you agree? So, psychiatric diagnosis. Suppose there is a depression causing insomnia. So, I will use antidepressant that have increased sedation. One of the very famous antidepressant that has very high sedation is mirtazapine. That's why, although mirtazapine is an antidepressant, in low dose we use it as a hypnotic. Mirtazapine is 3 doses: 7.5 mg, 15 mg and 30 mg. So if depression as a cause of this, we use mirtazapine. Some people use trazodone. Okay, that is also an antidepressant with high sedation. So do you understand, the choice of antidepressant will vary depending on the patient's symptom profile. If anxiety is a cause of insomnia, then I will prefer benzodiazepine. Now, which benzodiazepine to use? We usually use clonazepam or etizolam or alprazolam. The good thing is it's very easy to remember the doses because all three of them come in 0.25 or 0.5 milligram. Just you have to remember while giving this drug to anyone that these drugs have high dependence potential. So we can't give this for long period. They are to be used SOS. These drugs have high dependence potential, so they are not supposed to be used for long period. If there is a diagnosis of anxiety disorder established, I would rather prefer them treating properly with SSRI rather than just putting them on benzodiazepine. Do you understand? Suppose schizophrenia is a cause of insomnia. So here antipsychotics become the drug of choice. And many antipsychotics have high sedation like quetiapine, olanzapine, etc. So they will take care of insomnia. Do you understand this? So if it is a primary insomnia, we prefer giving a pure Z group of drug, zolpidem. In primary insomnia, zolpidem can be used. It comes as 5 mg, 6.25 mg, 10 mg and 12.5 mg. In primary insomnia, we mostly prefer zolpidem. It has less abuse potential, less dependence potential as compared to benzodiazepine. I am teaching this topic as if you can actually prescribe, being an MBBS doctor, the correct medicine for insomnia. An MBBS doctor, according to me, is supposed to know how to prescribe a medicine in insomnia. It's not that all the cases require medicine. There's something called as non-pharmacological management of insomnia. One of the good non-pharmacological method of insomnia is sleep hygiene. There are many techniques of sleep hygiene, like maintaining a sleep routine, having a lighter meal near bedtime. There are many techniques of sleep hygiene that help in non-pharmacological management of insomnia. Yes, you can use zolpidem in depression or GAD associated insomnia as well. Can be used. Because if it can be used in primary insomnia, it can be used in secondary as well. So may I summarize, how do you approach a patient of insomnia? Patient come with chief complaint insomnia. Approach to a patient. You will ask, is there disturbed quality? Is there disturbed quantity? If it is disturbed quality, if it is disturbed quantity, difficulty in initiation, that is cutting the sleep from the first half, or early morning awakening, cutting the sleep from the later half, or frequent nocturnal awakenings. Can you take this history? I believe this should be known to all first year postgraduates of psychiatry as well. How to approach a patient of insomnia, quality or quantity. It can be both also. Or not satisfied with the sleep, difficulty in maintaining day activities due to non-refreshing sleep. Do you understand this? Can you take a history of insomnia now? Can you understand? Can you ask the patient how to, क्या अब आप इंसोम्निया वाले पेशेंट से ये पूछ पाएंगे कि आपको किस तरह की नींद की प्रॉब्लम है? नींद आने में तकलीफ़ होती है, सुबह जल्दी खुलती है, या रात में बीच बीच में बहुत बार डिस्टर्ब्ड होते हो, या फिर आप अपनी नींद से सेटिस्फाइड नहीं हो, नींद कम होने की वजह से दिन में काम नहीं कर पा रहे हो? फिर आप अदर सिम्टम पूछेंगे कि हाउ टू डिफरेंशिएट वेदर प्राइमरी इंसोम्निया और secondary insomnia. Secondary insomnia, what are the common causes? Number 1, anxiety. Number 2, mood disorder. Number 3, substance use. Number 4, psychotic disorders. Number 5, dementia. Primary insomnia, prefer zolpidem. Secondary insomnia, treat the cause. Is this much summary understood to all of you? Emily Munshi in the live chat is asking, what is the difference between sedative and hypnotic? You are hyper before your exam. I gave you a drug to calm down, calm down, calm down, calm down, calm down. This is called sedative. You are normal and I gave you a drug and you slept. This is called hypnotic. I didn't want to take this topic very complicatedly. I have tried to simplify, summarize the topic to the best I could. This is just a basic understanding. I have not kept very hi-fi slides. I have not kept, too much deep into the concepts of sleep. I'm not going into neurotransmitter managing sleep. Literal, practical, clinical advice. If I am a psychiatrist and you are in my clinic, this is how I would have taught you, being an MBBS doctor coming to my psychiatry OPD. Do you get it? मैंने बिल्कुल ऐसा रखा है जब मैं एक मेडिकल कॉलेज में असिस्टेंट प्रोफेसर था और मेरे पास कोई इंटर्न सीखने आता है और मैं उसको कैसे सिखाता हूँ कि आप इंसोम्निया को कैसे मैनेज करेंगे. Yes, you can use antihistaminic, but again antihistaminic का side effect है sleep. That's why you are using that side effect as an effect. Technically, every sedative in low dose is hypnotic in high dose. So benzodiazepine are sedative hypnotic, and zolpidem is a pure hypnotic. Yes, insomnia can be present in thyroid disorder. There is something called as insomnia in non-sleep or non-psychiatric disorders. Insomnia can be seen in hyperthyroidism. Insomnia can be seen due to certain medicines like modafinil. The stimulants cause insomnia. Insomnia can be without a psychiatric diagnosis, with a medical diagnosis as well. Do you think what we have covered today is helpful to you as a clinician? Do you think that this understanding what is the difference between sedative hypnotic versus what is the difference between pure hypnotic, this understanding that what is a primary insomnia and what is a secondary insomnia was important for you as a clinician? So this is how I write prescription for a patient who comes to me for insomnia. Yes, melatonin is used. I didn't go into non-conventional treatments. So this is how I write. This is my prescription pad. Zolpidem, 10 mg, 1 tablet. at bedtime. When the diagnosis is primary insomnia. This is how I write prescription. Let's say 10 days. Understood? And when it is anxiety leading to insomnia, suppose a student comes to me before exam, not able to sleep, clonazepam 0.5 mg, secondary insomnia. This is how I write prescription for exam anxiety causing insomnia. Do you understand this? I have brought my own prescription pad also here just to tell you how do I write. Some people require 0.25 and some people require 0.5. Done. So this was me, Dr. Sachin Arora. I hope today's session on insomnia helped you a little. Thank you very much for listening live or recorded. Okay. Thank you very much. Wish you all the best to all the practicing doctors over here. I hope as a psychiatrist I was able to contribute something to your knowledge in the last 30 minutes of my video. Thank you.